So, let me take you. This is a quite intimate. It's just you and me, yeah. It's a private presentation. Oh, I would stay here. Sorry. Let me take you through some of the guidelines we have for best practices in cross-linking in 2020. These are my financial disclosures. And first of all, before you even treat keratoconus, you want to know how prevalent is keratoconus. Hello, this is Farhad Hafezi from Switzerland. We are here at ESCRS 2019, and I will speak about best practices for 2020 in corneal cross-linking. These are my financial interests, but in fact they do not apply for this particular talk. Before even starting to cross-link, we should have a closer look at the prevalence of keratoconus. And most of the current ophthalmologists will still have learned in their textbooks and during residency, keratoconus is a non-inflammatory disease, 1 in 2,000, which is the definition of rare disease. And if you look at where this comes from, you will find this one paper that was published in 1986 in the American Journal. And this is one of the highest cited papers in the field of keratoconus research. It's a 48-year clinical observation period that was conducted in Minnesota. Published in 86, 50 years of follow-up. So they started in the 1930s. They started to check whether the population between 1935 and 1985 had keratoconus. Now if you think of the technology that was available in 1935, 45, 55, they basically used the scissor reflex, and that's it, retinoscopy. Now let's look at what has technology done in the past 50 years. As we all know, it has improved so substantially from this mode to modern Scheimpflug imaging. So technology, in fact, should probably give us a more precise hint on the real prevalence of the disease. This is one issue. And Scheimpflug imaging for sure should detect with a greater sensitivity keratoconus present in a person. That's one aspect, so improving technology, but the other aspect is also Minnesota is not the rest of the world. And so we know that we have a big geographical dependence of the disease. Taking these two things together, we started a pilot study with our foundation, Light for Sight. Light for Sight is a non-profit that tries to increase the awareness for keratoconus and give access for treatment, and we have started in Switzerland 7 years ago and are in 42 countries now, trying to promote the idea of cross-linking children, adolescents, but also screening. So we took, I personally took a Ph.D. student in Riyadh, Saudi Arabia, and we started measuring children and adolescents. And what we did is we went into university hospitals that had no ophthalmology. So just the emergency room of a general pediatric hospital. We put a pentacam there and we started measuring a little more than 1,000 eyes to determine the real prevalence with modern technology in a Saudi Arabian setting. The criteria for keratoconus were quite massive. We did not want to argue about borderline cases, we wanted to find clear and distinct cases. And what we did is we measured 1,044 eyes, and then we sent the U12 files to two independent corneal refractive surgeons. One is Brad Randleman, the editor-in-chief of the Journal of Refractive Surgery at USC Los Angeles. The other was my postdoc Emilio Torres, a trained cataract refractive surgeon. And they looked at the topographies, and in 99% of the cases they had exactly the same judgment of the corneas, either normal or keratoconus or borderline. In 9 cases only, they had to talk about whether it really is disease or rather normal. This is a very good agreement. And what we found was quite surprising, astonishing. If you put these 9 disputable cases into normal, then we would have ended up with this prevalence, 3.8%. If you put all these 9 corneas into disease, then we would have ended up here. After the consensus, and both surgeons spoke to each other, this was the final prevalence. So looking at 5% in the pediatric population in Saudi Arabia, I think you cannot really speak of a rare disease anymore. And here we plotted the literature of the last 20 years. The first paper up here is the Kennedy paper from 1986, and Kennedy was at 0.05%, and now the study we published in the British Journal is at 4.8, 100 times more frequent. We took this pilot study, and what we are doing right now is our global study. So we are using some of the partner sites from our foundation and are currently running this same very simple, straightforward protocol in 11 countries, 4 continents. We have Russia, Israel, Mexico, Peru, the US, Egypt, Switzerland, and so on. And we have collected almost 5,000 eyes, but we will probably end up with 15,000 to 20,000 eyes. The idea is to have a global map of prevalence. Why is this important? Well, we need to really know which countries have a higher or lower prevalence of the disease, because this means that you also will get more support from your government. A rare disease gets less support. A more frequent disease gets more research support, funding for new therapies, etc. This is really important to know. Okay, this is detection of ectasia. The next step is how to treat ectasia. And of course, when we speak about treating keratoconus, we think of corneal cross-linking. We know that the method is well established. That's an old movie, but very nicely filmed, of an epi-off procedure. So how to cross-link we know. The question is when to cross-link. When is the right moment to cross-link a patient? And looking at when to cross-link, our group has worked quite a bit over the past 10 years on that topic, and we've published more than 100 papers peer-reviewed on cross-linking technology. Now, what my current approach is, in children, I cross-link immediately. I do not wait for documented progression. Why? Our group published a paper back in 2012 where we looked at the natural progression of keratoconus in that age group, and we came up with 88% of progression. So 9 children out of 10 between the age of 6 and 19. And in spite of these findings, I do not wait anymore. The study didn't have a very high number of children, but I just reviewed a paper that is in press now from an Australian group that has had 600 eyes of children recently and has found a natural progression of 77%, quite similar to the 88 we have. So most surgeons nowadays would say, children we treat immediately, in adults I still wait for progression. How to treat these cases? In children, I would always go back to the Dresden protocol. We all know that the more you accelerate cross-linking, the less efficient you get. And even the protocol we use in adults, the 10 minutes protocol, works nicely in adult cases with the less aggressive form of keratoconus. But when you have an aggressive form, children, teenagers, ectasia after LASIK, go back to the Dresden protocol. It's just even more efficient. Another question is when to retreat. How many of you perform cross-linking, if I may ask? One clinician and 2 clinicians. Okay. Have you had the need to re-treat patients? Not yet. Okay. So let's look at when would we have to retreat a patient. What I usually do in my clinics is I treat a patient and I wait half a year. And after this half year, I can decide, do I have success? If success is given, then I can look at further methods on how to improve vision. Wavefront guided surface ablation, scleral lenses, we start even earlier. So success is one possibility, but there is also ongoing flattening. Success with an improvement of the Kmax readings. Once this starts, I wait. This can sometimes take 2 years, 3 years, 4 years, 5 years of continuous flattening, and that's good. So I will not do anything until the cornea is stable. And in some patients I waited 5 years. The patient will be grateful forever, will never leave you because he trusts you. You don't just perform a surgery, you wait until it makes sense. But what about the cases that will fail? The percentage of failure, even in Dresden protocol, EPI-off is 3 to 7%. So if you treat 100 patients, you will have a few that fail. And failure means ongoing progression, re-cross-linking. So, and I see this after 6 months. If after 6 months I see that re-cross-linking is necessary, I do it, and I usually use mitomycin C because you will have quite a bit of haze, just like in a PRK. And that's the short term. What about the long term? That's a different ballgame. Let's say you treat a patient, and do you need to retreat the patient after 5 years or 10 years? Let's see what is known in the literature. This number is relatively new. The collagen turns over roughly after 6, 7, maybe 8 years. That means if I treat your cornea, in 8 years there is no more cross-linked collagen. It's just your natural cornea. Keep this in mind, please. And the other element is, the older we get, the stiffer we get. We all know that 20 years ago it was easier to get up in the morning, and today we are stiffer. Our cornea gets stiffer, so age-related increase of biomechanics. Now, let's just think about this. Let's take a patient, and the patient gets stiffer anyway, the older he gets. And I cross-link the patient here. After 8 years, 10 years, all the CXL effect is gone. So at the age of 37, this is a keratoconus cornea without cross-linking effect. If the patient is stable, it's because of his age, not because of CXL. And I think you can see where I'm going. What happens if we cross-link a 12-year-old? How old is a 12-year-old after 10 years? 22. 22 means young enough to still be progressive. And we are analyzing our 10-year data now. It's almost 15 years now with all the follow-ups that we have in Zurich, and we see a clear trend. The younger the patient was at the time of the first cross-linking, the higher the likelihood of a second procedure. And after all these years, no mitomycin. You can just re-cross-link the normal way. But and this is why it's important to tell your teenage patients, yes, we need the follow-up every year, and especially after 5 or 6 years, because we might need to do a second treatment. Okay, so when to retreat. Now the follow-up, just a few words about the follow-up. You of course know about the demarcation line. Theo Seiler and I published this in 2006. The paper took 1.5 years to be accepted in cornea because they didn't believe us. They said, no, there's no line. The biggest argument was, how can you do cross-linking for 10 years and after 10 years you come and tell us there is a line? Have you not seen this line before? Honestly, this was one of the reviewers' questions. Then we came up with a nice argument. We said, the slit lamp was invented in 1915. The first forked stress lines were described 25 years later. It took somebody 25 years to see these lines in keratoconus. So we were able to show the demarcation line. Now, knowing that there is a line and the depth of treatment, I usually see my patients for the first 4 days, then after 1 week, 4 weeks, and 3 months. And at 3 months, I do a pentacam, but I do not necessarily do the pentacam for the reasons of corneal topography. Even if I sometimes see massive changes already after 3 months in a pentacam, the problem is I cannot rely on these measurements. Please don't use the pentacam after 4 weeks for height data, because you will always have a certain degree of haze, and the haze makes your anterior evaluation of the cornea totally unpredictable. So don't even look at the data too much with the patient, because you might see an increase in keratoconus after 4 weeks and it's only artificial because of the haze. Just look at the densitometry if you have that module. Who is using a pentacam? Okay, who is using the MS39? Okay, we should have do we have a densitometry module? I only have it for 6 weeks now. I'm not sure, okay, but I like this module in the Pentacam because it helps me just giving a number to the haze. Of course, I look at the slit lamp, but if I have such a high number, I usually go to more steroids. After 6 months, this is the first time when the haze shouldn't be so substantial that it makes detection of changes hard. So at 6 months, I look at outcomes. And of course, in the very early days, we thought that we would see something like that. We thought that stability would mean the same image. Not true. In many cases, we see this. In about 30% of the successful cases, we see a flattening effect. And Eberhard Spörl has published this quite a few years ago already, that once the cornea starts flattening, this is cross-linking, the cornea can flatten over years and years. And we have some cases that flatten for 10 years now, continuous flattening, never stop. Is anybody doing Athens protocol? Combined refractive laser procedures? I've been arguing with John Kanellopoulos for almost 10 years now because he has a huge merit. He brought, can give you some amazing results. This is the first patient we had treated with that new nomogram. This was back in 2012. 37 years, and as you can see, a vision of 0.6 with a certain refraction. And of course, we tell all our patients, this is not about emmetropia, it's about better quality of vision. This was the same patient afterwards. Way better. So this was very encouraging. Still slightly irregular, but way better, and increased CDVA. Another example, a lady that had a refraction of -11, 0.6 vision, and this is one of the nicest cases we had so far. This is how she came out. So she had 20/20 vision afterwards. Laser vision correction into keratoconus treatment, that's great, but I do not agree to combine it. Why? Because I have seen so many complications and so many wound healing problems, and on top of everything else, please remember, everything we do in medicine follows the normal distribution. Everything. So if we do a Dresden protocol epi-off, most of our patients will behave like this, the normal way. But some patients will behave very strangely with massive flattening. We published on this in the British Journal 8 years ago, and in one case out of 200 we had flattening of 8 diopters, 9 diopters, 10 diopters. We now had a case of 20 diopters with the Dresden protocol. It's very rare, but it happens. Imagine you do a simultaneous laser on such a patient. He will be massively in a hyperopic shape. That's still handleable, but manageable. But what with the 3 to 7% of failure? Do you really want to do a laser treatment on a cross-linking that fails in 7%, and on top of it you remove tissue? Bad idea. And this is the reason why I never liked the combination. The sequential approach makes much more sense to me. First cross-link, wait, and then do your laser. If there is a failure, well, treat the failure. If there is flattening, wait. If there is stability, use the laser immediately. But I usually wait half a year. See, this is a case of flattening. That's not customized cross-linking, that's epi-off Dresden protocol. 6, 7, 8, 9 diopters of flattening. Yeah. After how much time? 4 months. Yeah. So if I had done a surface ablation at the same time, I would be in deep trouble. Again, this of course also goes along with haze, but the haze would never mask this massive flattening. And flattening always means a certain amount of scar. This was 2011. We didn't have an anterior segment OCT yet. This is a Scheimpflug image. So any massive flattening always goes along with a scar. The scar would be a huge problem in a normal cornea. In a keratoconus cornea, funnily, sometimes vision even becomes a little better. So again, in a cross-linking outcome, we either have stability or we have ongoing flattening and we wait. We have failure until we recross-link. Just a word about this part here. Scleral lenses. Do you use scleral lenses in your practice? I use it a lot, but just to show you the capacity of scleral lenses, because this eye here, it's 80 to 85 diopters of steepening in a corner that has had a hydrops, and look how thin the stroma in the sensor is. It's 108 micron, and look how nicely the epithelium got thicker to compensate. I put this patient on the transplantation list because we didn't even get any visual acuity, and he didn't tolerate lenses. He came with the diagnosis of contact lens intolerance. And then my optometrist asked me, can I try to adapt lenses? And he adapted scleral lenses on a cornea that is 108 microns. And look where he got, 0.6 with the contact lens. It's amazing. So just keep in mind that visual rehabilitation can be scleral lenses, and frankly the scleral lens does a better job than I can ever do with the laser. The lens is by far superior in terms of visual quality. If I do a sequential approach with the laser though, I have one problem. This is an excimer laser shooting onto the cornea, flying spot, just very slowly. Each shot removes a certain amount of tissue. And this is all defined by the engineers building the machines. But what happens in a crosslink cornea? Does it remove the same amount of tissue? Because if not, then we will be very imprecise with our lasers. This was not known back in 2012, so we had to do the research around it. It took us 1.5 years. This was a directed research project with Schwind, and we determined the laser ablation rate of a single pulse in a crosslink cornea. It was 12% more than in a virgin human eye. And this is just important to know, because ever since, if you have a Schwind laser, Schwind took these data and introduced it into the machines, and ever since here you make a checkbox before treatment, and then the entire nomogram changes and adapts to a crosslink cornea, just to be more precise. Now another word about laser vision correction for keratoconus, because this is a really important and very powerful tool. If you look at improving vision with the excimer laser, then everything we use as doctors has been given to us by physicists and engineers. They tell us, yeah, if you want to get to 0 diopters and metropia, we need to apply a formula, the monolin formula, and we need to ablate the tissue, and so on, to finally get from here to here. And we have to have a certain fluence, a spot size, and it's all physical. Now, taking this into account, this is not a normal ablation pattern. This is highly customized. In a regular cornea, it's easier. You have very good nomograms. Even to this day, we use the monolin formula for the central 2 or 3 millimeters, and then you have more sophisticated ablation algorithms. But performing a laser on a keratoconus cornea is more like sculpting, because you have dozens and dozens of possibilities on how to adapt your refraction. Who is doing wavefront guided treatments for keratoconus? Okay, which platform are you using? The Schwind platform. Okay. At this year's Cross-Linking Congress, we will have another course on irregular corneas and ablation. So let me just walk you through how we do this with an excimer laser like the Schwind. We start with the subjective refraction. In the case of this patient, the refraction was +6 more or less, -5 and 30 degrees. And then the laser gives us a proposition. It says, okay, if you want me to get to emetropia, I want 113 microns of stroma in a keratoconus cornea. That's a bad idea, way too much. So from now on, it's all about reducing the maximal amount of ablation. A first step is, here for example, tell the laser, frankly, I don't care about where we end up in the sphere and the cylinder, because sphere and cylinder I can correct with glasses. I just want more regularity. To do so, you can tell the laser, to calculate with or without constraints and say, just try every plane you find. And if you find a plane that makes less ablation and ends up at +2, okay, let's do it. And so the laser calculates and then tells you, okay, if you can live with +1.1 corresponding to -1.5 as a residual refraction, I don't need 113, I only need 88 microns. That's already better, still too much. The next step is, let's look at this refraction, and oh, I should have had the topography here. The subjective cylinder is not really a cylinder. It's a part cylinder and it's a great part vertical coma. The subjective sphere is not really sphere only, it's sphere plus spherical aberration. If I address both in the same ablation, I will overcorrect. So you always have to check your Cernicke pyramid and see, oh yes indeed, there is a huge amount of spherical aberration that is part of my artificial sphere. Same accounts for vertical coma, and then you can decide, or horizontal coma in this case, and then you can decide for every single Cernicke coefficient, shall I switch it on or off? Shall I treat it or not treat it? What makes sense? And you can then say, okay, this is a rather central cone, so I will minimize for depth. It's a rather peripheral cone, I should rather minimize the ablation for volume, and then again see what happens if you let the machine give you some propositions by switching on and off Cernicke coefficients, and then we get closer to a good profile. In this case, the machine said, let's keep the horizontal coma and the positive spherical aberration and do sort of a treatment in the periphery, but less extreme, and it goes down from 88 to 53 microns. This is even better, but it still might be too high. If this is still too high, you can play with the optical zone, but you have to start from 0, because you cannot, at the end of a wavefront guided calculation, change the optical zone, because then all your wavefront errors are not matched to the optical side. So you restart from 0 and look at the cone on your topography. You want to treat the cone. You cannot just treat it with an optical zone that stops in the middle of the cone. So there is a lot of non-standardization in this approach, but it's very challenging. We sometimes need 2 hours to calculate one eye. And when we're not happy, we send it to the engineers of Schwind, and they get back to us with a counter proposition. it's like on a market, and then we decide where to end. And there are so many ways to roam. But applying this now, what we always tell the patients, we can never promise you that. What I can promise is, in most cases, you will have a benefit, but it's hard to put a number to the benefit. And what is missing in our field is how to describe quality. We all know if you can read this logi, you might have a vision of 0.8. But if the logi is all blurry and you somehow still can read it, that's 0.82. So, but the quality of the image can be very different. And this is what many keratoconus patients say. Sometimes we only increase by one line and the patient is unhappy. In others, we increase by one line and the patient says, wow, but the image is much better. The quality is better. If you have a much more extreme cone, you still can do nice things for the sensor. So the cone, if you look at it, again, this was very asymmetric, and now it more looks like a regular astigmatism. And irregularity means, irregularity always is good, because regularity, because it means better symmetry, better correction with glasses. And another added benefit, of course, is it's easier to adapt contact lenses, and the patient can wear glasses from time to time with a better vision. And even in topographies that resemble more a mixture between keratoconus and PMD, you can get quite astonishing results. And again, still multifocality, but much less pronounced. So, yeah.
What is the difference between keratoconus and PMD? This is inferior seeing.
Yeah.
Difference.
Well, we do believe that keratoconus and PMD are substantially members of the same family, but you have a clear inferior steepening. If you ask me how many
in long age, 40, for example,
in older patients, yeah. But if you ask me how many real PMDs I've seen in 20 years, maybe 6 real PMDs with like a periphery of 200 microns. What we more often see is oh no, a PMD, Yeah, but a real PMD is extremely rare. A real PMD means
Bell sign is present. Bell sign is present in PMD. Bell sign.
I'm sorry?
In thickness map, Bell sign. Bell sign is hallmark of PMD. In thickness map. In thickness map. Bell sign.
What is PEL? That sign. Yes, absolutely. But this case is not a real PMD because the thinning in the periphery is not substantial. A real PMD gets down to 200, even 150. And again, I've almost never seen one. A real keratoglobus, I've seen only 2 cases in 20 years. But even in cases that have a PMD-like bow-tie pattern, yes, you can improve on that. So this is my current approach on when I treat my keratoconus patients, and we are running a large research group that does everything from prospective multi-center clinical trials to transgenic animals and gene expression experiments in the lab, based in Zurich, at USC Los Angeles, and now we're building a sister lab in Wenzhou, China. Thank you for your attention. Thank you.
The previous slide, there was only one line improvement
Yeah.
from 2040 to 20.